So I have nothing to disclose. Here is a step-by-step approach in goal of CLI treatment. Because the patient with CLI exposed to severe ischemia, revascularization is optimal treatment, and the short to intermediate treatment goal is to relieve the ischemic pain, cure ischemic wound, and avoid major amputation. After overcoming the CLI condition, long-term treatment goal is to improve the patient QOL, ADL, and the mortality. Absolute goal for CLI patient is to improve the patient mortality with well-being. These are many innovations of CLI treatment within the current decade. These innovations dramatically contribute to CLI outcome improvement. In other words, people who engage the CLI treatment should understand these. Here are two major studies comparing the endovascular therapy versus surgical bypass therapy in CLI patients. Basic trial was a consistent of the prospective multicenter randomized trial, while the critical study was a prospective multicenter registry. According to these two studies, if amputation-free survival is the endpoint, result of endovascular therapy is comparable to that of the surgical bypass therapy. In terms of the evaluation of ischemia, skin perfusion pressure plays an important role for assessing the severity of ischemia and predicting wound healing. If skin perfusion pressure is over 40 mm mercury, 100% wound healing rate is expected, and this modality has been mentioned in the ACC guideline. Regarding the assessment of wound severity, Wi-Fi classification is an alternative grading. Currently, ESC and ESVS 2017 guideline recommended that management of the patient with CLI should consider the three components of this Wi-Fi classification system. Revascularization should always be discussed as its suitability is increased with more severe stages. It is not too much to say that clinical outcome of CLI-treated endovascular thanks to the innovation of the technique, especially in the below-the-knee artery region. These are many techniques as a CTO revascularization strategy, and there is a general agreement for acquiring a better outcome. I think these techniques should be routinely mastered in the physicians who perform the endovascular intervention. Angiosome concept and wound brush are clinically important to define the endpoint of CLI intervention. Before emerging these concepts, it is hard to clearly decide whether the procedure could finish or not. After widespread applying these strategies, we can decide the procedure endpoint with strong confidence. What is the true treatment strategy below the knee region? Because the diffuse calcifying and totally occlusive disease are commonly found, and the stent-based treatment is the ideal, but the full metal jacket using the stent is not realistic. DCB-based treatment is a clinical ideal, but have no general consensus in this field. Further investigation should be warranted. After revascularization for vessel, quality of wound care directly and critically impact the patient's prognosis. Recently, negative pressure wound therapy plays an important role for wound care and is essential therapy for especially severe wound. Ultimate clinical question is real-world practice with whether the revascularization would improve the CLI mortality. We therefore conducted the priority registry. This priority registry is the first prospective multicenter real-world study assessing the prognostic impact of revascularization for poor risk CLI patients. Here is the 1-year survival rate of the two groups, revealing the main result in this study. At 3 months, the survival rate was 83% in the revascularization group and 76% in the non-revascularization group. These are significant intergroup difference. However, at 1 year, survival rate was 55% versus 51% with no significant difference. 1 year overall survival rate was not significantly different between the revascularization and the non-revascularization group in poor risk CLI patients. To explore for subgroup in favor of revascularization, We subsequently performed the risk stratification analysis. The screening analysis suggests that the subgroup with non-older age, non-heart failure, and non-rest of pain CLI were in favor of revascularization. We also compared the clinical outcome between the surgical reconstruction and endovascular therapy for Japanese patients with CLI in today's real-world setting. After propensity matching analysis, the 3-year amputation-free survival rate was not different between the groups. Amputation-free survival at 3 years in both groups was 52%. This result was similar to previous Basil and Critis study. So we also performed the interaction analysis providing the 5 factors more favorable for surgical reconstruction and another 5 factors less favorable for surgical reconstruction. If the total point of the patient is +1 or more, these patients are suitable for surgical reconstruction. On the other hand, if the total point is -2 or less, these patients are suitable for endovascular therapy. The subsequent interaction analysis suggests that CLI with severe wound status might be more fit for surgical reconstruction, while those with poor general condition might benefit more from the endovascular therapy in terms of amputation-free survival. In this presentation, I summarize current innovation of CLI treatment. Further innovation will be needed to improve the CLI outcome. Thank you very much for your attention.
Thank you so much, Osamu.